Imagine being unable to climb a flight of stairs without gasping for breath. Walking to your mailbox feels like running a marathon. Even simple household tasks leave you exhausted. For millions of people living with heart failure, this is daily reality. But here's something most people don't know: your heart can learn to work better, and you can regain the ability to move, live, and thrive. Welcome to the science of cardiac rehabilitation, where evidence-based exercise transforms what was once considered an irreversible condition into a manageable journey toward recovery. Heart failure doesn't mean your heart has stopped working. Instead, it means your heart's pumping function has weakened, making it difficult to supply your body with the oxygen and nutrients it needs. This leads to breathlessness during activity, persistent fatigue, swelling in the legs, and a dramatic reduction in quality of life. For years, the medical advice was simple: rest and avoid physical exertion. But research over the past 3 decades has completely reversed this thinking. The landmark HFaction trial, published in the Journal of the American Medical Association in 2009, studied over 2,300 patients with reduced ejection fraction heart failure. Those who participated in supervised exercise programs showed remarkable improvements: a 4 to 5% increase in peak oxygen consumption, significant quality of life improvements, and, most importantly, reduced rates of hospitalization and death. The ExtraMatch meta-analysis found that exercise therapy reduced all-cause mortality by approximately 35% and hospital readmission by 30%. These aren't marginal benefits. They're life-changing outcomes that rival many pharmaceutical interventions. So what actually happens when heart failure patients exercise? The answer reveals something profound about human physiology. When your heart's pumping capacity is compromised, your entire body adapts in ways that actually make the problem worse. Skeletal muscles atrophy from disuse. Mitochondria, the powerhouses of your cells, decrease in density. Blood vessels lose their ability to efficiently deliver oxygen. Your autonomic nervous system becomes imbalanced, with chronic stress hormones dominating. Even your breathing muscles weaken, making every breath more labored. This creates a vicious cycle. Reduced heart function leads to less activity, which causes muscle weakness, which makes activity even harder, which leads to more inactivity. Patients become trapped in what researchers call deconditioning, a state where the body forgets how to move efficiently. Exercise therapy breaks this cycle by targeting the entire system, not just the heart. When heart failure patients engage in properly prescribed exercise, several remarkable adaptations occur. Skeletal muscles increase their mitochondrial density, improving their ability to extract and use oxygen from the blood. New capillaries form, enhancing blood flow to working tissues. The stiffness of blood vessels decreases, reducing the workload on the heart. Perhaps most importantly, the autonomic nervous system rebalances. The overactive stress response calms down, while the recovery-promoting parasympathetic system strengthens. Think of it this way: even if your heart can't pump much stronger, you can train your body to need less from it. This is the essence of cardiac rehabilitation, making the whole system more efficient so that a compromised heart can still support a full life. But there's a critical question: how do we exercise safely when the heart is already struggling? This is where the science of exercise prescription becomes crucial. Unlike telling someone to just walk more, cardiac rehab uses precise physiological measurements to create individualized programs. The key metric is called heart rate. Reserve the difference between your resting heart rate and your maximum heart rate. Using the Karvonen formula, therapists calculate target heart rates that provide benefit without overloading the cardiovascular system. For example, if your resting heart rate is 70 beats per minute and your maximum is 130, your heart rate reserve is 60. Exercising at 50% intensity would mean a target heart rate of 100 beats per minute, challenging enough to stimulate adaptation, but safe enough to sustain. Cardiopulmonary exercise testing takes this even further. By analyzing breath-by-breath oxygen and carbon dioxide levels during exercise, clinicians can identify the anaerobic Threshold, the exact point where your body shifts from aerobic to anaerobic metabolism. Exercising just below this threshold maximizes cardiovascular benefits while minimizing fatigue and risk. For patients taking beta blockers medications that limit how high heart rate can climb, subjective measures become equally important. The Borg rating, a perceived exertion scale, asks patients to rate their effort from 6 to 20, with somewhat hard around 13 being the sweet spot for therapeutic exercise. The typical prescription combines several elements. Aerobic exercise forms the foundation: walking, cycling, or treadmill work for 20 to 40 minutes, 3 to 5 times per week at moderate intensity. But aerobic exercise alone isn't enough. Resistance training is equally crucial because heart failure patients often develop sarcopenia, age-related muscle loss that's accelerated by chronic illness and inactivity. Strength training 2 to 3 times per week. Focusing on major muscle groups like the legs helps rebuild functional capacity. The ability to stand from a chair, climb stairs, or carry groceries depends on leg strength, not just cardiovascular endurance. And here's something fascinating. Resistance training improves not just muscle strength, but also metabolic efficiency, helping the body use nutrients more effectively. Some research even suggests that high-intensity, interval training, short bursts of harder exercise alternated with recovery periods may produce superior results in carefully selected patients. A typical HIIT protocol might involve 1 minute at 85 to 95% of peak capacity, followed by 1 to 2 minutes of low-intensity recovery, repeated 6 to 10 times. Studies show this approach can significantly improve ejection fraction and oxygen consumption, though it requires close medical supervision. But exercise is only part of the story. Heart failure rehabilitation succeeds when it addresses the whole person, body, mind, and social context. Nutrition plays a critical role. Many heart failure patients develop cardiac cachexia, a wasting syndrome where the body breaks down muscle tissue faster than it can be rebuilt. Adequate protein intake, typically 1.1 to 1.5 grams per kilogram of body weight daily, becomes essential. Branched-chain amino acids, vitamin D, and iron supplementation may also be necessary, depending on individual deficiencies. Medications must be carefully coordinated with exercise. Beta blockers blunt heart rate response, requiring adjustments to exercise prescriptions. Diuretics can cause dehydration and electrolyte imbalances, especially potassium and magnesium, which affect muscle and heart function. ACE inhibitors and other blood pressure medications can cause dizziness, particularly when transitioning from lying to standing. Close communication between rehabilitation staff, physicians, and pharmacists ensures safety and effectiveness. Perhaps most overlooked is the psychological dimension. Approximately 30 to 40% of heart failure patients experience depression or anxiety. Fear of triggering another cardiac event can be paralyzing. Patients often ask, what if exercise makes things worse? What if I collapse? What if this is all pointless? These aren't irrational fears. They're understandable responses to a frightening diagnosis. Cognitive behavioral approaches help patients reframe these thoughts. Instead of, I can't do this, the focus shifts to, what can I do today? Progress tracking, recording walking distance, monitoring perceived exertion, celebrating small victories builds self-efficacy, the belief that you can influence your own health outcomes. Group-based cardiac rehabilitation programs add social support, reducing isolation and providing encouragement from others facing similar challenges. The maintenance phase extends indefinitely. The goal shifts from recovery to prevention, avoiding rehospitalization, maintaining functional independence, and integrating healthy behaviors into daily life. Home-based programs, community exercise groups, and telemedicine support help patients sustain progress long-term. Technology increasingly enables this long-term engagement. Wearable heart rate monitors, smartphone apps that track activity and symptoms, and remote monitoring systems allow healthcare teams to stay connected with patients between visits. A patient who feels short of breath at home can check their oxygen, saturation, and heart rate. Consult predetermined guidelines and decide whether the symptom warrants medical attention or simply means they need to slow down. This real-time feedback reduces anxiety and prevents unnecessary emergency room visits. The science is clear. When we help hearts move, we help people live, not just survive, but truly live, climbing stairs to grandchildren's bedrooms, walking through parks, traveling, working, loving, and engaging with the world. That's the promise of cardiac rehabilitation, backed by decades of research and thousands of transformed lives. If you found this information valuable, please give this video a like and subscribe to the channel. For more evidence-based health content, thank you for watching, and remember, your heart's capacity for recovery may surprise you.